kick us off. My name is Julia Simhai. My pronouns are she, her, hers. I am going to be moderating this session, so welcome and thank you for joining us. I also have my counterpart, Lala Kaiser, here as the tech host. So if you run into any Zoom issues, you can reach out to her and we'll make sure it gets squared away. Everyone is muted now, but if you have a question during Q&A, we really do welcome you to come off mute and share your question that way. The chat box is also available for questions. There will be time at the end for them, so feel free to drop them in if you want throughout the presentation, but we will save them until the end. And if you're comfortable doing so, please add your pronouns to your Zoom name. You can do that by going to your little box and clicking the 3 dots in the corner and then hitting rename. All right. So this session has been generously sponsored by Champ Software. So we thank them for their contributions to the conference and supporting this event and CPHA. We have one presentation that we'll be having for this session, about 25 minutes long, and then 10 minutes for the Q&A. And we're really lucky for this session. I'm excited to hear about some innovative approaches to reaching hard-to-reach populations. And based on the abstract, I think we're going to really benefit by learning about what works and what didn't work, which I always really appreciate in conferences, so you know not to try the thing that didn't work. So that I think we'll get some really good value out of this. So I will turn it over to Sydney Arns to present using web-based tools to reach hard-to-reach populations and improve prevention outcomes.
Wonderful. Thank you so much, Julia. I appreciate you. If you could just give me a thumbs up and make sure that you all can see my slide. Awesome. Great. As Julia mentioned, we're going to talk about some strategies for incorporating technology in traditional data collection methods. And I wanted to start off by introducing myself. My name is Sydney Arns, and I'm an evaluation analyst at the Colorado Department of Public Health and Environment within the Office of STI, HIV, and Viral Hepatitis. So today I wanted to discuss some traditional data collection methods and then discuss how STI and HIV data is collected and its purpose. And then I want to share some findings from a web-based interview demonstration project that we launched, and it ran through a couple of months in 2023. And then finally, I want to share some challenges that we experienced with the demonstration project, and then share out some associated lessons learned and considerations for incorporating technology into traditional data collection methods if you are interested in doing so yourself. So we can gain a better understanding of a population by using traditional data collection methods, including surveys and interviews. But what if the population you wish to gain more insight into is difficult to access? The U.S. Census Bureau identifies these groups as hard to count populations. When it becomes difficult to find or locate or contact or connect with individuals from these groups, we can miss out on opportunities to understand their experiences, limiting our ability to address health-related barriers and promote health equity. So I wanted to take a moment to briefly discuss the pros and cons of using surveys or interviews as primary data collection methodologies. So surveys can be easily standardized and can be administered at the participant's convenience, which allows for rapid recruitment and statistical analysis. However, survey questions can be misunderstood, requires questions to be designed properly, response bias can affect results, they require respondents to complete them, and if you can't administer the survey to everyone that you wish to, it can lead to missed opportunities for data collection. Now on to interviews. Some of the advantages of conducting interviews is that you have the ability to request clarifications and capture the participants' emotions, as well as gaining additional insights. Interviews although those are the positive, interviews can also be time consuming, are prone to errors, require strong interviewing skills, can be challenging to navigate sensitive topics, especially STIs and HIV, and can lead to missed opportunities to hear first-person narratives when populations are difficult to recruit or reach. So when aiming to improve health prevention outcomes, it is necessary to consider the limitations of traditional data collection methods, especially when trying to reach those hard-to-reach populations. Next, I will share how sexually transmitted infection, or STI, and HIV data is collected and its importance in monitoring prevention efforts. So in the state of Colorado, labs and providers are required to report reactive or positive test results for HIV and STIs, including syphilis, chlamydia, and gonorrhea. This data is then collected, analyzed, and monitored by the Office of STI, HIV, and Viral Hepatitis. And we use that data to detect and monitor outbreaks, develop, implement, and evaluate intervention programs throughout the entire state of Colorado. So partner services is an evidence-based public health intervention. And the CDC recommends that all clients who are newly living with HIV or who have received early syphilis results receive partner services. So our DIS, or our disease intervention specialists, are responsible for conducting field investigation activities, which include conducting partner services interviews, which are traditionally conducted in person or over the phone, contact tracing, partner elicitation and notification, prevention counseling, and linkage or referral to other services. Partner services can have a significant impact on reducing the burden of STIs in our community. However, partner services activities may be difficult to conduct due to a lack of DIS capacity, inability to locate clients, or when clients refuse. So this flowchart here provides a super broad overview of how we deliver partner services to our clients. So due to capacity limitations, this process is different for clients with reactive HIV or syphilis results compared to other STIs such as gonorrhea. So while we are notified of reactive STI and HIV test results, it's so important for our staff to connect with their clients so that they can follow up with them and see if they could provide additional referrals to additional resources. So I want to draw your attention to the yellow stars in this flowchart, which represent the missed opportunities to interview clients. So when we fail to reach our clients, it really hinders our ability to promote STI and HIV prevention. So next, I'm going to discuss the project that we put together and its purpose to address these missed opportunities. So the web-based interview tool, or WBI for short, was originally developed in 2020 as a survey in REDCap. This tool served as an alternative for when clients refuse an interview with DIS for syphilis or HIV cases. It includes questions related to demographic information, HIV status, sexual history, and substance use. Clients can complete the WBI on their phones or computers at their own convenience. And in addition, our tool offers clients to request referrals to services such as pre-exposure prophylaxis, PrEP for HIV, linkage to care and treatment, additional STI and HIV screening and testing, and syringe access programs. So typically speaking, when DIS can typically conduct interviews if they locate clients. So if they actually can get the client on the phone, we usually see that clients agree to those interviews with our DIS. So we haven't had the best luck with testing the original WBI tool for its efficiency to reach clients. So we decided that we wanted to expand this tool to reach additional clients. So as I previously mentioned, clients who receive reactive test results for other STIs usually do not receive partner services due to current capacity limitations. However, within the Office of STI, HIV, and Viral Hepatitis, all clients who are 18 years old or older receive reactive gonorrhea test results are sent letters by our case ascertainment team. To assess the effectiveness of the technology in providing partner services, we created a new gonorrhea-specific survey by expanding the original tool. And then we launched the pilot project starting in March and through July of 2023. So this purpose of this project was to introduce a new and incentivized technological solution to expand the reach to our clients and so we can gather that essential core epidemiological data. This project was designed to achieve the goals and was actually funded by the Strengthening the United States Response to Resistant Gonorrhea, or SURGE for short, project. SURGE aims to improve gonorrhea surveillance and infrastructure in the United States so that we are better equipped to respond to antibiotic-resistant gonorrhea. The WBI was open to all Colorado residents who received a positive gonorrhea test result during the year of 2023. And then after the clients completed the survey and their test results were verified, they were then offered a $20 Amazon gift card as an incentive to thank them for their time. Before this tool was launched, detailed plans for implementation and evaluation had been created to ensure the success of this project. I also want to note that because we wanted to reach everybody who was eligible, this survey was also available in English and in Spanish. So to advertise the WBI and reach individuals who are not originally calling the case investigation team to follow up after receiving those letters, we developed various marketing strategies. So in attempt to reach all eligible clients, I want to highlight this again, all of our materials were translated in both English and Spanish. So first, when the case ascertainment staff added inserts to follow up with the clients who received reactive gonorrhea test results, we put together an insert that they could also add to those letters. These inserts encourage clients to call and mention that they were interested in the survey. And these letters were, we have an example of what the insert looked like on the screen, but they were super broad because we wanted to make sure that if anyone, like a family member or if a client had a different address, we wanted to make sure that we never gave away any information about health identifying information in these letters in case they were opened up by somebody that it wasn't addressed to. So we really wanted to make sure that we reflected that too in our insert that we were adding. But the downside with adding these inserts to the letters is that letters are only sent to clients that are aged 18 and older, and those who have valid addresses on file. So we decided to kind of take a step further and kind of identify additional ways that we could reach other clients, maybe that didn't have addresses on file and maybe were under the ages. So we also really wanted to aim that with our marketing strategies that we identified areas throughout the state with high gonorrhea morbidity. So then we created palm cards and flyers and distributed them to local public health agencies and community-based organizations located in those identified areas. And then last, we collaborated with SE2, a marketing company, to create a social media campaign. And the surveys was then advertised on social media platforms such as TikTok and would show up in Google search results when clients were searching gonorrhea testing near me, gonorrhea symptoms. We identified those key terms so that they would be redirected to the survey too. And we really wanted to make sure that these campaigns were reaching clients located in the zip codes in the areas we previously identified. So to show some of the findings, so this is one of the dashboards that was used to monitor the project and displays the summary of completed surveys. In total, 65 clients completed the survey, and almost all clients accepted a gift card. 73% of clients completed the survey after receiving the follow-up letter in the mail. This is another dashboard that was used to track the follow-up for additional resources in partner elicitation requests. Out of all of the clients, less than a quarter requested additional assistance. In total, we received 21 requests, with most of them being for gonorrhea treatment options and assistance in accessing HIV testing. Only 2 clients requested assistance with anonymously notifying their partners, and the RDIS staff attempted to locate the 18 named partners. If located, the partners were screened and for gonorrhea, other STIs, and HIV. Unfortunately, just under half of the clients were located but refused partner services. So ultimately, this WBI method was less effective than traditional methods in eliciting partners, but it was still valuable in connecting clients to additional resources. So I wanted to compare the outcomes of the completed WBI tool with other clients who received reactive gonorrhea test results and were eligible to complete the WBI but did not. So firstly, the percentage of clients who completed the survey and were living with HIV was higher than those who did not complete the survey. Secondly, the percentage of clients with a previous STI was roughly the same for both groups. And thirdly, the percentage of clients who had been previously interviewed by a DIS was higher for those who had completed the WBI as compared to those who had not. While we reached 52 new clients, this project exposed and highlighted some challenges to consider when incorporating technology into traditional data collection methods and when trying to reach hard-to-reach populations. So next, and the kind of final point in this presentation, I really want to take the time to walk you through some of the shortcomings of this demonstration project and offer some lessons learned and considerations if you are interested in implementing a similar tool or interested in incorporating technology into your existing data collection methods. So I wanted to share some things that happened and then kind of the lessons learned that we want to incorporate if we plan on implementing or continuing with this project in the future. And so one of the kind of initial pitfalls we ran into was that we originally purchased tablets for key providers in areas with high gonorrhea morbidity or primarily serving homeless clients. And we wanted them to house these tablets in their clinics so that they could have clients complete the survey right within their clinic. Excuse me. It's allergy season, sorry. But unfortunately, the tablets could not be distributed due to IT security reasons, which impacted our goal to reach clients with no access to internet. So kind of the main takeaway from that is that technology cannot replace traditional methods. We know that partner services works. It's been used for decades, and it's an effective strategy for reaching out to our clients and offering them sexual health counseling and referrals to additional services, and confidentially notifying their sexual and needle sharing partners. But it's important to consider that if you want to add technology in traditional methods, that you must identify the best fitting method for your population, and also take into account factors like the digital divide, or the fact that access to technology is not universal or always accessible. And then the next kind of little challenge we experienced was that while we created implementation and evaluation plans, the plans were created months before the launch of the project. And so therefore, some of the elements in the suggestion timeline were deemed infeasible. So these plans were helpful to ensure that all staff members were involved in the project were kept informed and were definitely useful in creating real-time Tableau dashboards to monitor the project performance. Although these plans also did highlight the processes that were necessary for prioritizing client confidentiality. So the main lesson from the next lesson from that is that it's important to develop implementation and evaluation plans. It is also important to monitor your data collection process kind of from the start of the project and throughout the duration, as recommended by CDC. Also, data security and client confidentiality should be prioritized, always, but especially when incorporating technological methods. While our social media campaign was effective, we actually ended up reaching, definitely exceeded our benchmark numbers, and our reported impressions were quite, definitely way more than we expected. We learned that really putting together a large-scale media campaign that reaches the general audience is not really effective when you're trying to reach a really specific part of the population. So we had many people that did not actually receive positive gonorrhea test results at all, not even just in 2023, they were completing the survey and sometimes multiple times. We also had some issues with some bots completing the survey. And so it was important for us to make sure that we added additional security measures, and we turned on a CAPTCHA so that we can make sure that we're trying to get as many valid responses and reduce those fake bot responses to our best ability. So once we noticed that we were seeing an influx of invalid surveys, we ended up going back to our social media people and looked at the language that was used originally in the campaigns, and we changed that language to emphasize the eligibility requirements. So we made sure that we were very specific on who was eligible to complete the survey and that they would only receive that gift card if they were eligible. So this helped to slow down the invalid surveys, but it did not totally resolve the issue. So number 3 is that you need to identify your priority population. It's so important to use the right language to target your audience and avoid marketing pitfalls. And then since we use REDCap, this meant that we had to actually manually enter the information from REDCap into our in-house database, which was super time consuming. And manual data entry can cause delays in case investigation work. So the WBI would have been way more sustainable if there would have been a way to link the data using a file upload or having the systems, that just actually talk and speak together from the start. So our last lesson is that data systems that don't communicate with each other can lead to challenges. And also keep in mind that data entry can be very time consuming. So in sum, traditional methods of collecting data may not always be appropriate for populations that are difficult to reach, which this has led to missed opportunities to understand communities better and promote health equity. While the WBI demonstration project had some issues, the use of similar tools could be helpful, especially for us when we're experiencing future outbreaks or times of limited staffing, or when we want to investigate cases that are now not currently receiving partner services. So one way to expand case investigation is by incorporating these methods into data collection processes. However, it is essential to consider any gaps that may exist, incorporate insights from our lessons learned, and create effective implementation strategies accordingly. And with that, here are my references. Here are some additional resources if you would like to learn more about partner services and how it looks within the state of Colorado. And here's my acknowledgement. Thank you to everybody who was involved with this project. It took a large team. And with that, I thank you so much for your time.
Great. Thank you for that presentation. A lot of good information shared. We do have time now for our Q&A, plenty of time. So feel free to put things in the chat or unmute if you want to ask a question. I will kick us off while folks get their questions formulated. I was sort of curious, it was almost, I think, one of the last points that you made around trying to bring some technology into the methods that you know work. And if you are trying to do that, and given that you did see some success with people accessing resources, are there ways to leverage that while still going with some of the traditional methods that were more successful in other areas?
Yeah, absolutely. I think that's a great point. And I think, you know, when we try to add technology or use technology to assist us when collecting data, I think the problem is that we often just associate technology with being innovative and, automatically leading to streamline, improved efficiency and things like that. But it's just important for us to, yeah, observe the positives, especially from this project with we were able to definitely reach out to more clients, and we were able to connect our clients with those resources. And I think that just shows, I think that would happen without this tool. I think that we have, usually those conversations occur as one-on-one interviews. And so we're not always keeping track of all of the services that folks may request during those conversations. And so, the fact that we had kind of a paper trail, and we could follow up with our clients to make sure that they were receiving the information that they requested, I think that was super beneficial. And I think going forward, if we decide to revisit this tool and relaunch it, that is definitely a part of the survey that we are going to continue to prioritize for sure. Thank you.
Yeah, thanks for that. Anyone want to unmute and ask a question? I have another. I'm just curious if you know how the campaign that you ran compares to potentially other campaigns that have been done by CDPHE on different topics, or if you were able to sort of borrow from learnings from other departments or program areas when you were planning for that.
Absolutely. I think this, I guess I have a couple of thoughts about that. I think we have done I haven't been involved with a lot of the marketing campaigns. This was kind of the first one that I personally been involved with. And I think the thing about this campaign that shocked all of us, including the agency that we worked with, was how TikTok you can just get a message out to thousands and thousands of people within hours. And I think that unlike other social media platforms where, if you have to actively scroll on Facebook, stop on it, look at whatever you were presenting as an advertisement, click on the advertisement, spend time on the page, wherever it takes you to. But with TikTok, you're just scrolling, and, where some of the videos can be like 3 seconds long, when they're scrolling, you're just seeing an advertisement right in front of you, like that was an impression for us to track and monitor. And so while we were able to see how many people actually engaged, with that link. And then we actually were able to see how many people clicked through the survey and who completed it and everything like that. But I just think that this was different because we did focus heavily on using TikTok, which is something that I don't think we've done, since it is a newer platform. We hadn't used that platform to kind of push our campaigns. But even with the agency we worked with, they were very shocked at the numbers that we were getting back. And the engagement also, I wish that we would have thought around like comments and how people were engaging in the comments, because it popped up a couple times when I was just scrolling through, or like friends were scrolling through, and they would send me the TikTok because it was linked as a video. And I was just going through the comments, and I wish that we would have been able to, go through the comments and actually share out some resources that way, because I feel like it would have been beneficial to engage with those comments. That's another thing that we definitely missed out on.
Great, thank you. All right, other questions?
I can, I guess, ask a question.
Yeah.
I was a little quiet. So you mentioned you're using REDCap for this, and I'm currently learning a lot about REDCap as well, and doing some of my own survey stuff with it. And you had the issue was transferring data that you got into your own personal or tracking data that you use. It does other, because I know there's a lot of pros and cons between REDCap and Qualtrics and other ones. Was that the only one that you use with the, I guess, with this survey in particular, or do you use other softwares that may be able to make that transfer easier?
Yeah, thank you for that question. Great point. I think so. We only use REDCap for this project. The problem is that our in-house database was built specifically for the type of data that we are collecting, while considering, we wanted to make sure that we created a data system that was in-house, so that we could also protect client confidentiality. So the problem with that is that the data is not, a lot of the data that's collected is actually qualitative data, because it's, we're taking data from conversations that we're having with our clients and then adding it to our data system. So a lot of that data actually is entered as comments or as qualitative information. And so one of the problems is with this specific survey is that we're taking, data that's typically collected during these conversations and interviews that our staff are having with our clients. And then we're taking that format and then, using it as a survey, so that the data is just not translational from REDCap to our in-house database. And so even if, we export it as a data file and try to import it to our database system, it's just the matching process between the variables is just, it doesn't work for us.
Okay, nice. And I'll take a look at your actual survey because you said it was listed in the list on what I can see in REDCap, right? The PDFs and the under uh WBI.
Uh, I didn't add that to my presentation. That was just the form that we created, just office specific.
Okay. Cool. Well, I mean, nice job on that whole entire thing too, and being able to get that out there. And it's such a difficult topic and difficult population to reach. And um, yeah.
Thank you. I appreciate your question. Thank you.
Any more questions? We have a couple more minutes if you've got them. Okay, I've got one in chat here. How are questions in the surveys generally formulated, especially with asking sensitive information regarding STI and HIV?
Yeah, absolutely. Great question. So with partner services, as I mentioned, the CDC has created, and also some regionally based training groups have put together wonderful interview guides to make sure that our DIS staff are conducting interviews in very trauma informed and in very client centered ways. And so we wanted to make sure that the way that those questions are asked, just during those in person or over the phone interviews, that those questions were asked in similar ways when we put together this survey. So we make sure to just avoid using any stigmatizing language, anything that any verbiage that would kind of direct blame or responsibility toward the client, making sure that we were, offering resources, not because we thought that they would benefit from them because of the behaviors they, participate in, but that everybody was offered the same, access or referrals to the resources, just making sure that we're being client focused and client centered. And also, the issue with kind of talking or reaching out to clients and talking about sexual health in general is unfortunately stigma. And unfortunately, it's something that we have to acknowledge, even though if we do, if we're doing these interviews in person, or if we're, sending the survey out to our clients, stigma is something that we definitely just have to acknowledge. And especially when we have to think about like response bias, and we deal with that, with folks, not wanting to give up partner information in person for in-person interviews or over the phone interviews. We saw that too with this survey. And it's just an an unfortunate part with kind of eliciting this information from our clients.
Thank you. Okay, we have time for probably one more, if anyone's got final question. Okay, Ellen, I see your hand up.
Thank you. Thanks, Sydney, for the presentation. And you might have covered this, but can you please describe your timeline a little bit, especially as far as follow-ups? Thank you.
Yeah, thank you, Ellen. That's a great question. And so our timeline, so our original timeline was that one of our goals was that we wanted to decrease the time in which a person receives reactive test results, and then the timeline of like when they get the letter in the mail from our case ascertainment staff, and then the time that they take to actually contact the staff if they did want to call back and discuss their recent test results with them. And so we knew that process just takes a while because, it's snail mail also. And then also we're kind of, waiting for the client to actually respond back. So that definitely could extend that timeline. So we thought that this would be a great opportunity, especially if clients were seeing the flyers and the palm cards displayed in the clinics in which that they were receiving their treatment, or where they were being initially screened and tested for gonorrhea. We thought that would increase or decrease the amount of time between their positive test results and the actual follow-up with the survey. However, we didn't see that necessarily because a lot of people were filling out the survey. Some people were filling out the survey after they saw the survey advertised. And so some people had test results from, January, the first week of January, and they completed the survey in, the end of April. So that wasn't necessarily a good measure. And then the timeline, just for kind of in general, was that, once a client completed the survey, 3 times a week, I, alongside with some other staff, went in and validated the responses using some of that surveillance data that I mentioned that we received from providers and labs. And I confirmed that those those responses were valid, or I kind of put them into a pile of, invalid responses. And then I sent out the gift cards 3 times a week during the duration of the project. And then our goal was that during that week, we would respond to any of the follow-up requests or reach out to the client for additional information if we had any questions or we wanted to know some more information from them. So our intention was to do it within a week of receiving the responses or the completed survey. However, we did have a couple of delays and some issues come up during that time. So our usual response time, could really vary from follow up that day to follow up within around probably less than 10 days.
Thank you so much.
Thank you.
All right. Well, thank you, Sydney, for a great presentation. And I commend you all for trying something new to reach hard to reach populations and just like continuing to experiment and make sure that services are getting out to folks who need them. And thanks everyone for the questions and the great Q&A exchange. Couple short announcements before you head out. The slides for this are on the Sketch website, so feel free to go there. I know Sydney provided a couple links and references at the end, so you can get to them through that if you would like. There is a conference evaluation that will come out after the conference ends. Please do fill that out. It really helps the planning committee to make sure we're making a conference that you all want to attend. So there is a raffle for everyone who completes the survey within the next 2 weeks to win one of two $50 gift cards. So next up, there's a 15-minute, we're a little bit early, so it'll be close to 20-minute break for you all until the next session begins at 1:30. It is another concurrent session, so you'll have a few options to choose from. You can check out the full schedule on Sketch to figure out which one you want to go to. And I think that wraps us all up. So thanks again, and hope to see you at some more sessions today and tomorrow.